we'll go ahead and get started in another 30 seconds. And just so you all know, we are recording today's event, and I did just hit the record button. So we'll go ahead and get started. I want to thank everybody for coming today, and welcome to our COVID-19 forum with Dr. Noah Nessun. I am Heather Drake. I am the membership manager of the Maine Public Health Association, and I really just want to thank everybody for coming and for being members of MPHA. Your support enables all of us to continue our strong advocacy, training, and education efforts, including providing events like today's to all of you. So thank you very much. We do have just a few housekeeping items. I think everybody should be muted upon entry, but if you're not muted, we ask that you do please mute yourself, except for when you're asking a question, which we'll have time for at the end of the event. You do have the opportunity to have your video on or off, but just make sure that you know it's on when it's on. As I mentioned a minute ago, we are recording today's session, so we'll have a copy available afterwards that I'll send out to all the registrants. If you are having connection issues, just try to close any programs on your desktop that you might not need access to during the webinar. Sometimes that can help clean up some space. And again, we'll take questions at the end, so you can go ahead and use the chat box or unmute yourself and ask them verbally. I will stop sharing for a second, and I just would like to take a minute to introduce Dr. Noah Nessun, who will be our speaker for today. Dr. Nesin has been a family doctor in Maine since 1986, first in private solo practice, and then in federally qualified health centers. And he served as the chief of staff of the Penobscot Valley Hospital, as medical director of the Health Access Network in Lincoln, Maine, as chief quality officer at Penobscot Community Health Center, and he's now the chief medical officer at Penobscot Community Health Center. Throughout his career, Dr. Nesin has led efforts in evidence-based prescribing and in practice transformation to improve efficiency and use healthcare resources judiciously. Dr. Nesin has mentored physician assistants, nurse practitioners, and medical students, along with family practice residents throughout his career. Dr. Nesin has received a variety of recognitions, including the Maine Academy of Family Physicians Family Doctor of the Year, the Lisa Letourneau MD Award for Excellence in Primary Care, the Maine Primary Care Association Physician Excellence Award, and the Maine Medical Association President's Award for Distinguished Service. And at MPHA, we are also honored to have Dr. Nesin as our board member and board vice president. So I really want to thank you for speaking with us today, Noah, and we'll turn it over you to begin the program.
Thank you. That's a very kind introduction that I wrote, and proof that if you live long enough and stay at the same career long enough, these things just sort of naturally happen, I think. So thanks for that. I'm going to share my screen to give sort of a brief overview. I assume that's showing up now, Heather. That's shared properly.
Yes, we can see it.
To go through an overview of where we're at in the pandemic as of today, and then really to open this up to a question and answer and discussion, which is, I think, the real value of these kind of opportunities. And I've done this more broadly on Facebook a few times since the pandemic started, and there are always a lot of great questions that cause me to pause and think. And I think it's really important that I give the disclaimer at the outset that I'm not a public health expert. I'm a public health advocate. I don't have a master's of public health. I'm a family doctor who's worked in Maine my whole career, and I care deeply about the people of Maine and our communities, and in my work, especially those communities we serve. And I come at it from that perspective, but I don't want to hold out my thoughts or opinions as those of an expert in public health. Fortunately, we have great public health experts in this state, like Dr. Shaw and Dr. Stephen Sears and Dr. Dora Mills and others. And much of what I think and promote is based on what I learned from people like them, because their expertise is really critically important at this time. So two things you'll learn from this first website. It's the Worldometer. Probably many of you are familiar with it. It's worldometer.info is the website. It's got really good, very current data and information on the pandemic. That's the first thing. The second thing is you'll see that apparently it recognizes that I've been looking for new mountain biking shoes, because that's what's going to pop up in the advertisements on this website. So I apologize for that. So this is the circumstance in the US right now, over 1.4 million cases, sadly 85,000 deaths, and clearly we're headed to way over 100,000 deaths in this country from COVID-19. And as public health experts had said, had we acted 2 weeks earlier in this country, we may have prevented a very significant majority of those deaths. And I think all of our concern as people interested in public health now is, are we acting too early in relaxing social distancing restrictions? And are we going to see more what could have been preventable deaths as we enter the plateau of this nationally, and then whatever the downside curve of this wave of the pandemic looks like, because this is just the first wave of the pandemic. And thankfully, over 300,000 people have recovered. The data in this table is really helpful and allows you to shift around and prioritize to see, for instance, where Maine ranks in our testing density. So you can see, going from the Idaho, where they have the most tests per million population, that's this last column over here. We're kind of in the middle of the pack in Maine. So you can look at that both state by state, and if you go to the world circumstance, you can see how the United States is doing. And the United States, notwithstanding the claims of the administration, is 41st right now in the amount of testing we do per capita. And of course, while we only have under 5% of the world's population, we have 28% of the deaths from this disease in the world. Understanding that there are questions about the veracity of the reporting from China and perhaps from Russia and other places, but nonetheless, that's so dramatic that it really does reflect something lacking in our response to this pandemic. And then the other kind of interesting information that's available is that this is the daily number of new cases in the US, where you can see generally a downward trend, but almost all of that is, as you may have seen in a recent New York Times article and graph, is because New York, the New York metropolitan area, Connecticut, New Jersey, and New York, are clearly on the downside of their wave of this pandemic. And almost all of that downward trend nationally is because of what's happened, in the New York metropolitan area. And if you separate out that from the rest of the data, you'll see generally an upward trend in the rest of the country, or at best, the beginning of some plateauing in the rest of the country. And then you see these spikes nationally, which are to some extent reflect the outbreaks that occur in places like meatpacking plants and their contacts. And certainly in Maine, we're especially sensitive to that, where we, at our shelter at Hope House, when we had that outbreak a little over 2 weeks ago, there was a big spike that day in numbers. The cases at the food processing plant in Portland have created a spike, and our overall denominator of positives in Maine is so low that dramatically impacts what our curve looks like. But of course, those are real cases and people who have real contacts with other people and a real public health concern. And then this is the trending in deaths in the US from COVID, the reported deaths from COVID on a daily basis, and very spiky looking, even though you can see sort of a general trend. Again, this, what looks like a downward trend, is almost completely reflective of the improvement in the New York metropolitan area. And none of these trends is inevitable, of course. This is just a reflection of what has happened. It's not a projection of what will happen in the future. And that very much depends on how we continue to respond or not to the pandemic, which is one of my key concerns. There's all kinds of other really cool stuff on this website. Lots of graphs on where you can compare US to the rest of the world. And I probably should share one of those because it's pretty dramatic. So if we go to the world data on this website and graphs, this one, which is a cumulative number of deaths by the number of days since the first 100 deaths. And look how the US looks compared to these other advanced countries. So this, separate from testing, this just is a demonstration of how out of sync we are with the response of other, these other countries that have been hit by this. Even if you take China out and say, well, their reporting may not be reliable, Germany, Iran, France, Italy, Spain, we're way off the charts with that. And similarly, well, I won't hunt forever for it, but there's a similar graph on new cases that looks just the same. So that's where we're at. Where we're at in Maine, this is the red line is 7-day trending in Maine. This is from the Portland Press Herald, which is a pretty good graph. But you can see it's very sensitive to these spikes that occur from outbreaks in congregate living situations and in work environments like the food processing plant. I think what Dr. Shah and his team have found reassuring is that our R naught in Maine remains around 1, meaning that that we're not seeing exponential growth, that because of our social distancing, we've managed the spread of this disease in a way that each person is not infecting several other people. And so although this curve is not reassuring, that R naught value, which is held pretty steady now, I think for a couple of weeks, and the low level of acuity of the low level of need for hospital beds and the relatively low level of acuity compared to other states of the people who are hospitalized, reassures them that with adequate contact tracing and testing, they apparently have come to the conclusion that they can begin to relax some of the social distancing restrictions in this state, especially in the counties where there's not community spread. And this is the table all of us are seeing all the time, summarizing our cases, which are 1,515 right now, and unfortunately 66 deaths. So I'm going to eliminate each of these so they don't interfere with my signal as we move ahead. This is a CNN site, which is kind of cool, which just shows our doubling time for this disease. And you can see in Maine that we're among the better states in our doubling time. This also is very sensitive to the day-to-day numbers, but overall, we've been at about a month of doubling time for quite some time. So doubling time is the amount of time it takes this disease to double our numbers. And early on in this pandemic, in the world, in the US, and in Maine, the doubling time was under 3 days, which had it persisted at under 3 days, and it wouldn't because of the rural nature of the state, but had it persisted at under 3 days, by mid-April, we would have had 35,000 cases in this state. So our work at social distancing, in addition to the rurality of the state, has really helped us dramatically, and this relates to the R naught value, to the number of people each person infects as well, has really helped us dramatically impact the doubling time, which makes the whole pandemic much more manageable. No less tragic when somebody is impacted with serious complications or death, no less concerning when any individual has an infection for them and for their contacts, but for the health delivery system and for the management of the pandemic, this has remained pretty encouraging, and Mainers have been, pretty responsive as a population, notwithstanding the craziness in the protests or in some of the social media posts that you see. Mainers have been pretty compliant with social distancing, and this has been the result of it, which is super encouraging, and hopefully it remains. And I think Dr. Shah said in his press conference yesterday that so far mobility data in Maine remains pretty reassuring. And I'm going to show you a couple of other things about this. So this is the IHME model, the one that's been widely publicized, widely criticized, probably because it's widely publicized. One of the criticisms is, well, they keep adjusting their projections. Well, that's what models do. They're simply trying to reflect the reality of the current circumstances. And what the IHME model has done in the last week has begun to incorporate actual mobility data of a population. And you can see in Maine, we've begun to become more mobile through the month of April. And their projection now is what they think could happen in Maine. And you can see that they're projecting still a pretty significant reduction from normal levels of mobility. And given that assumption, they improved their outlook for Maine from a total of I think mid-90s deaths by August to now a total of 75 with a range of 67 to 87. All of that is so sensitive to things like, long-term care facility outbreaks and the impact that it can have in long-term care facilities. We always have to remember the limitations of models like this. And it's so dependent now on our ability to maintain social distancing, even with the reopening of retail businesses and some, in-restaurant dining in some of our counties, that if we instead see this tracking upward, we'll see a much more dramatic result in that. So if we go to North Carolina, for example, and I don't know the details of what's going on in North Carolina, but you'll see that they are projecting shortly quite a significant increase in mobility in the population of North Carolina in this model based on what they're seeing currently. And as a result, North Carolina's predicted total deaths was quadrupled in this new model compared to what the last update was on I think, a week ago. So our continued participation in the management, each as individuals, and the decision-making we make around our mobility and our contacts with other people and our ability to promote that with our population is really going to determine how we do with this. This is the social distancing scoreboard from Unicast. And you can see that in general, Maine's social distancing grade is a D-. Yet we haven't seen a dramatic impact from that. And one possible explanation for that is that we have become more mobile, but it may be just people getting out and driving around, which is what rural Mainers do, rather than getting out to interact with other people. And we can break it down by county. I don't know where all of you are, but in Piscataquis County, people have remained pretty at home throughout all of this, and they're getting a grade B. In Penobscot County, we're getting a D. We had been as high as an A- at one time, and you can see that our mobility is trending up. That grade bill also includes the number of cases that occur, and the spike in cases from our shelter at Hope House, which is run by PCHC, changed this report card for Penobscot County as well. Last thing I want to share before we get to our discussion is this kind of cool data which is collected from smart thermometers. And they've been doing this for a few years now, and in doing it have been able to accurately project the course of seasonal influenza across the country for the last few years. So, when it's going to peak, when it's going to decline, and when it's going to go away. And so using those smart thermometers, what they saw, not surprisingly, in early March was a spike in febrile illnesses, illnesses with fevers, that was not projected. The actual projection for influenza is this blue dotted line, which prior to the data being updated had projected out into mid-May as a gradual decline. But what you can see is in our response, as we started to social distance in mid-March, we mitigated that spike in Maine in febrile illness, and actually ended the flu season 6 weeks early, because the flu is much less contagious than COVID-19. By implementing social distancing, we essentially ended the influenza season 6 weeks ahead of what the projected end of the season would have been. And you can see that by early April, as a population, we essentially had eliminated influenza and dramatically reduced what appear to be the COVID infections. And that fits with the sort of slow growth in the cumulative number of COVID infections we've had in Maine. So, you know, one of the arguments of people who are trying to minimize the impact of COVID, minimize the risk of COVID is, well, you know, 60,000 people die of influenza every year. It's unacceptable that we don't view that as a public health failure, that 60,000 people die a year of influenza when we have a pretty effective vaccine, not a perfectly effective vaccine, when we allow people who work in healthcare to decline that vaccine and risk transmitting that virus to the people we serve, and when some pretty straightforward, reasonable infection control measures and appropriate, not dramatic social distancing, but social distancing and separation, for instance, of people with respiratory illness from other patient populations in waiting rooms, and in other social circumstances, we could dramatically reduce that number. And it's scandalous that we accept up to 60,000 deaths a year from influenza. That's probably an overstatement as well of the number of deaths, and it certainly hasn't been that number the last few years. But the real answer to that argument is, of course, that we've seen 85,000 deaths in 2 months with COVID, and that's with really draconian social distancing in place. And we've eliminated influenza, this season's influenza, as a result of that social distancing. So the two are, of course, totally incomparable. So I'm going to stop talking there and close these websites so they don't interfere with my Wi-Fi signal. Stop sharing my page, and then we'll open to discussion.
Thank you so much, Noah, for that presentation. I hope everyone else found it as helpful and useful as I did, and really great to see the different websites to go back to and keep tabs on to see how we're doing in Maine. We did receive a few questions prior to the event, so we'll start with those, and then we'll open it up to others. One of the questions we received is, what recommendations do you have to protect Maine people from future pandemics?
Well, I think this pandemic will change the way we all live and work. I know within PCHC that we're making changes. You know, obviously telehealth is a huge change, and we may get into a discussion of that as well. But I don't think that's going away. You know, we can address people's needs in very important ways via telehealth, and we just haven't had the reassurance of sustained payment in a manner, and the limitations on payment, like you have to demonstrate, you know, the barriers for each individual patient before you initiate telehealth prior to the pandemic. So I don't think that's going away. In a rural state, of course, it makes a ton of sense. We're going to have better broadband in our rural areas to carry this off. But, you know, serving people from their home, you know, this is one of the Institute for Healthcare Improvement's fundamental principles, is you need to bring expertise to people rather than people to expertise. And telehealth goes a long way to doing that. But even within our practices, and I know this is going on across the healthcare industry, you know, we need to be much more thoughtful about infection control. And among the illnesses that we've always taken for granted, you know, like, you know, kids with colds in waiting rooms with people who have lung disease, and not having people hang out in waiting rooms, you know, using telehealth for check-in, and having people come at a time where they can be escorted directly into an exam room. We're going to use restaurant buzzers so people can wait in their cars, if they have a car, until they're actually ready to be seen. We're doing all of our pharmacy services as curbside services right now. As the cold weather approaches, we're going to have to create new ways of doing that. But in the warmer weather, really, you just need shelter from the rain to do that, which is much more straightforward. And I think in all businesses, we're going to have to think about social distancing. We're establishing more face-to-face visits in our practices, but doing it in a way that will allow all of our staff and providers and patients and the people who need to come with them to maintain 6 feet of social distancing, except for that interaction for their care, which means we won't have all of our providers and staff in the practice all at once, because their workspaces up to this point have not allowed for social distancing. And I think we're going to have to establish those as more normative parts of our work environment, which means more telecommuting in all businesses where that can occur. You can see that I'm working from home, and I've been doing that for weeks now to a very large extent, because my role is overwhelmingly administrative, especially in the context of this pandemic. All of those things are going to be changes. And then, we have more systemic things to think about in our society, like our responsibilities to each other, and our leaders need to start speaking, and we need to start teaching our public from grade school on, from early school on, our mutual responsibility for each other's well-being, especially in the realm of public health. Schools are going to look very different, I hope, going forward, and that even more importantly, students and staff who are sick in school stay home when they are sick, that we allow more appropriate social distancing in schools, masking is probably going to become much more normative when people are ill, or when there's an outbreak of a disease like influenza or other things. And of course, vaccines are going to be a big part of this discussion going forward. And I know there's another question about vaccines, where we can talk a little bit more about how tenuous a circumstance that may become as time goes by.
And we can jump right into that vaccine question. So what we received prior to the event was, one, whether you were involved and to what extent with Maine's most recent vaccination legislation and referendum. And, based on that involvement, whether you gained any new insights or observations that might be helpful in working with people moving forward who have vaccine hesitation, that either we can anticipate or mitigate before that comes to light, if and when, hopefully more when, we have a vaccination for COVID-19.
Yeah, hopefully we will have a vaccination. It's a big concern. So there was an article published in Nature this week that was summarized in the New York Times yesterday that emphasized, how tenuous our circumstance with vaccination resistance and anti-vaxxers are. By vaccination resistance, I mean people resistant to getting vaccines. And the fact that in social media, the anti-vaxxer point of view is promoted in a much more subtle fashion, in many more venues, and targeted at people who may be amenable to that message in much more subtle ways because of their perspectives on other things. Whereas the pro-vaccine information tends to be pretty cut and dried, because the science is cut and dried, and tends to be reaching only people who are already sympathetic to that message, and not people who might be subject to the opposite message through a more subtle approach. And so this study that was reported in Nature indicated that based on current patterns of messaging on social media, 10 years from now, it's likely, if those patterns continue, 10 years from now, it's likely that anti-vaccination messaging will be the much more broadly accepted normative point of view on social media. And that's tremendously troubling I was involved in the campaign. The people who carried out the campaign with the public face were incredibly effective, and the fundamentals of that campaign were that we knew at the outset that 90% of Mainers think that vaccines are safe and effective. And that's a very powerful position to start from, which is why having less money to spend and having a very short duration campaign, because the impeachment business was grabbing all of the public's attention. So really it was a 2 or 3 week campaign that we won overwhelmingly, because at a baseline, Mainers at this point in time have a very favorable view as a population about vaccines. Unfortunately, for highly contagious diseases like measles, you need to not only have a favorable view, but you have to have 90% of the population getting that vaccine. And when you have with this pandemic, messaging that's pretty widespread that the vaccine, is a World Health Organization conspiracy, that Bill Gates wants to implant microchips in people through the vaccine. And believe me, I have earnest people messaging me and emailing me, people I've known their whole lives and cared for, asking me, am I worried about microchipping the population? The message is getting out there, and I think we'll have more resistance to this than we did to that campaign. Fortunately, we don't have to have 90% vaccination rates with this vaccine to gain enough herd immunity, if this vaccine ever becomes available, to gain herd immunity. But I really worry about the efforts to undermine a potential vaccine long before it's going to be available, and what that might mean in pockets of populations, as we've seen with measles vaccine, where certain religious groups have been targeted with that messaging, and very effectively, like the Hasidic population in part of New York that had a measles outbreak, or in American Samoa, or in Maine there are some religious groups, and now that vaccinations have become inexplicably a partisan issue, I wonder how that's going to play out. Secondarily, during the course of this pandemic, what we know is that people who are open to vaccinating their children, those vaccines are falling behind because they're not coming in for well child checks, because their families are making rational decisions to defer that care. But when a population of kids are deferring that vaccine, especially if it's their first vaccine, under the age of 2, to the extent that gets deferred, it risks exposure and an outbreak that otherwise might have been prevented. That's a big concern. So all of us have worked throughout the pandemic to encourage people with children under 2 to bring them in for vaccines, and to create an environment in which they feel safer about that. At PCHC, we're separating to the extent that we can. We are completely separating in all of our practices people who have respiratory illnesses from everybody else. Unfortunately, the asymptomatic carriers of COVID-19 make that an imperfect system, so incompletely reassuring to our patients and the general public, but doing the best we can. But moreover, trying to create separate spaces for well child exams and immunizations to try to further reassure people about that. And I think we're going to have to get more creative about, again, bringing that service to a family in a way that makes them feel totally safe about it. And that gets into the public health realm. And I know our public health infrastructure has been decimated in this state, and that perhaps the pandemic, almost certainly the pandemic, has slowed the progress on rebuilding it, a process that was going to take years anyway, considering how badly decimated means only 10%. And of course, our public health workforce has been reduced by much more than 10% over the course of the prior 8 years. And so it was going to be a long process to rebuild that workforce anyway, and that capacity, and that's been further delayed by this pandemic. So that's worrisome. But I think that's a partial answer to routine vaccinations for kids as well, is to bring the vaccinations to them, so they don't have to make a decision about going into a public space to do that preventive care.
Thank you, and you're segueing nicely into all of our questions. The other one we had, thinking about those of us who are currently working in public health and are part of that public health infrastructure, do you have ideas or recommendations on what we can do as public health professionals that might be most impactful, either now or as we move forward?
I think probably everybody gets a sense of this, but I do think, Mainers remain pretty reasonable, common sense people for the most part, again, notwithstanding the nonsense on social media that goes around. But right now, public health is held in pretty high esteem. That's why you see people willing to listen to Dr. Fauci, why Dr. Shah has his own fan page in this state, that people who are calmly and transparently and factually sharing information have the public's ear right now. And so for people who work in public health, one, to make it known that they work in public health. And then two, I think our immediate need is for an unrelenting campaign to continue to share and even increase how much we share of factual information, of how much each of us as an individual living in this state, how much each of us in our own decision-making will impact the outcome from this disease. So one, promoting the idea that Maine acted early, and because of that, if you look at the impact, our rate of deaths per million population, we've done really well. We're in the top 10. I think we're 6th or 7th in that regard in states. And even among rural states, we're doing well. That the part of the tragedy is that the U.S. didn't act more earlier and more comprehensively, and still hasn't acted comprehensively. But each of us can mitigate that failure by our choices that we make now. And I think the more we can spread that very straightforward message, which has become mundane, but we have to think about new ways to spread it. That if you maintain social distancing, if you stay at home as much as possible, if you work at home if you can, if you wear a mask when you go out, if you wash your hands a lot, that each of us can mitigate the impact of this disease until there is herd immunity from a vaccine that we hope eventually develops. That no other path to herd immunity is acceptable. That arguments that that the vulnerable should stay sheltered and everybody else should run about and do their business will result in unnecessary death. And that kind of acceptance of the death of the vulnerable is an obscenity, that we just shouldn't tolerate that as part of our public discourse. And that we still don't know a lot about this disease. And as we learn things like the multi-system inflammatory disease that we're starting to see in children, we shouldn't be so sanguine about opening schools and risking children's infection with this, because although it's rare, if we broadly across the country open schools and expose millions and millions of children to the disease, that means thousands and thousands will get this disease and get this complication, and that's avoidable as well. We have to acknowledge the impact of dramatic social distancing, the negative impacts on things like education, and continue to innovate around that, on things like hunger and neglect and abuse. And again, that demands that we enhance our public health responses to those things, that we work quickly in Maine to rebuild our public health infrastructure, continue to work on that. And I know that Commissioner Lambrou, that's one of her fundamental commitments, but that takes time. In the short term, I think it's still sharing factual information and emphasizing personal responsibility in all of this, and refuting harmful misinformation like that Plandemic documentary. And by the way, the anti-vaccination movement played a very significant role in promoting that, and then in subtly editing it so that when it got banned on YouTube, it reemerged in a slightly edited form that didn't change the message at all. And that happened cyclically, repeatedly, so that it kept getting shared even after YouTube took it down. That kind of thing, these awful urgent care business owners in California who promoted the nonsense they were promoting, other, experts. If you can't see me, I'm doing air quotes. Experts, I don't want to disparage a specialty, but there's a medical provider, healthcare provider. They go on in a starched white coat and promote themselves as experts and spew, harmful nonsense about the disease. We have to refute all of that in an appropriate, probably not as pejorative way as I'm doing it to this group of people, but we have to refute that and be willing to challenge that and to mute it. So one of the things that happens on social media is, we get indignant and comment on timelines that have that as a post, and that simply amplifies the message. So we have to be a little more sophisticated about how we go at it. So commenting on it in a way that doesn't amplify it, like, going into instant messaging somebody has posted something like that, or creating a separate discussion from the one on which that post appears, it does not serve to amplify it. But if they've posted it and you go into the comments under that post, you're just further amplifying the post in the first place. So we have to be a little more sophisticated about how we go at that as well. I think that's, in the short term, really what's necessary. In the long term, we have to take advantage of this moment when the very significant majority of Americans value the public health perspective, to promote that public health perspective and make it real to people in contexts other than a COVID-19 pandemic. Why it matters in social determinants of health, why it matters in nutrition, why it matters in adverse childhood experiences and our response to them, et cetera.
Thank you so much. And we have one last question, which I think you've touched on a little bit in the others. But what is the greatest disruption to public health work in Maine due to COVID-19, and what do you see as the greatest opportunity?
I think the greatest disruption is the attention that has to be paid to this immediate public health crisis, but paired with what we know will be exacerbations of hunger and neglect and abuse and intimate family violence, and our ability to respond to those things, and its interference with the work to reestablish a public health infrastructure. The opportunity is what I just spoke about, which is to take advantage of this moment when a public health perspective is viewed as important and meaningful, and to engage people's imaginations and thoughtfulness about this, so that it becomes a more embedded value, both in an individual's personal approach to their community and everybody's responsibility in their community, and to the formal public health infrastructure to address concerns all of us share always, but over the prior 8 years, a public health response has faded from our sort of conscious framework for all of this. And so if you think about, the nurse who had heroically worked in West Africa on the Ebola outbreak and all of the nonsense that surrounded her return to Maine, that instead of a public health discussion, it became a partisan, discussion and attack on her personally. And that was because of the absence of a public health framework for addressing that, and the low value that people placed on a public health perspective to address what was essentially a no-risk circumstance for Mainers. And we have to reestablish that.
Thank you so much. So we'll open it up to everyone else. It's probably easiest to put your question in the chat box, but for those of you on the phone, please feel free to unmute and ask. We do have a couple that have come through already. One from Kip asking about the projection of a limited increase in Maine deaths seems to be based on continuing our same level of mobility. But thinking ahead to the summer tourist season, what if that mobility increases?
Yeah, well, I think you'll see the case rate and the death rate track right along with that mobility, and minus. So the opportunity, we have to mitigate that impact, and it's inevitable that mobility, that flatline mobility, is not going to maintain through the summer in Maine. Although again, I think to some extent mobility in Maine reflects my desire to go to camp, which is 50 miles from where I live. And that's how it is in Maine, right? That's how people live. When I get there, I won't be interacting with anybody different than I interact with at home, other than some loons and mosquitoes. That's part of what happens with mobility in Maine. But there's no question that there's going to be more social interaction as well. And if we have robust contact tracing and testing capacity, we can mitigate that to some extent. And I know that that's what the Maine CDC and the Maine Department of Health and Human Services are actively working on. We're working on it in PCHC. I know other healthcare entities as well. We do expect, for instance, within PCHC, in the very short-term future, to have our own very significant testing capacity, in addition to the state's publicly announced tripling of its testing capacity, which is a really important advance. And the CDC is working on, is actively increasing their contact tracing capability. I think, an example of a public health intervention success, I can speak about our success in our shelter at Hope House, where we had that outbreak a little over 2 weeks ago with, in a matter of a couple of days, 3 days, 4 confirmed cases, which created a cluster, which resulted in us doing universal testing, which identified 12 additional guests and 4 staff members who were positive. And I can tell you that as of today, the shelter is COVID-free, and that there are no new additional cases, save one person who was a partner of one of the confirmed cases, and they declined to be separated, so they were quarantined together, and that partner now is a presumptive case because they became symptomatic, but has been quarantined for more than 2 weeks now because their partner is quarantined. So that outbreak was totally contained within 24 hours of the cluster being identified, and in retrospect is now, unlike the proclamations of containment early on nationally in this pandemic, that outbreak was contained. We may get new cases at Hope House, and we may get a new outbreak. I can't predict the future, but it will be a different outbreak from that one. That outbreak has been totally contained. And as an aside, what we saw with our guests who've been quarantined for over 2 weeks is heartbreaking, which is when you give them a place to live that gives them dignity, we saw them dramatically improve. That they began caring for themselves in ways that we hadn't seen before, and engaging with others in ways that we hadn't seen before, and talking about the future in ways that we hadn't heard before. And as they've been moved back to the shelter environment, we've seen that improvement degrade, which goes to show that congregate approach to people experiencing homelessness is not the right approach, that housing is healthcare. And we saw that in microcosm in the people who were sheltered in hotel rooms, where they had their own bathroom, their own space, some ironically more autonomy than when they're in a congregate shelter, and their humanity expressed itself more powerfully, even in that very short term. And that's been a heart-wrenching and important lesson for all of us.
Thank you. Well, first, congratulations on containing and stopping the spread. And it's great to hear that there aren't any more new cases. And I think also, the silver lining is that we can learn, as you're saying, about other public health interventions that we can do to help people be healthier, like giving them housing. So I really appreciate that addition to the question.
We
We have
knew that
another,
already, but this is just a dramatic example of it.
yeah, it's great. We have one question similar to the last about balancing the concerns about our economy, especially means tourism and out-of-staters' contribution to the economy, with our need to continue to be vigilant in preventing an increase in the COVID spread. So I think you touched on it a little, but wanted to make sure that was asked.
Yeah, I mean, businesses are going to close and stay closed. You know, whether or not we reopen, more people will make rational decisions not to travel, and so it's not. Even if we absolutely open, I anticipate it would be a much lower rate of tourism than in summers past, and I hope we don't opt to do that. That the risk is too immediate, which will then require that we do more for our businesses and workers impacted by all of this, and that's a matter of political will. And I know we don't have unlimited resources, but you know, in the last 3 years, we've decided as political decisions that you know, hundreds of billions of dollars in tax breaks could be applied, and there's a potential resource there if there were the political will to reverse that, to help people who are going to be, you know, dramatically and permanently impacted by what's coming. You know, I think there is a balance to strike, especially with the testing and contact tracing capacity and with proper precautions, to help businesses, but and I'm not an economist. There's going to be a dramatic impact, and yet I don't think as a society we want to risk the illness and death that would come with a complete return to what had previously we had considered normal. And that discussion could be had, but it will be less effective if it's muddied by, you know, by purely partisan political considerations, especially electoral considerations, as opposed to a proper balance of business and public health needs, done in a scientific manner, which can be undertaken, but I'm not terribly optimistic about it on a national level. I'm more hopeful in our state, where that kind of collaboration and discussion is ongoing.
Thank you. And we'll switch gears a little bit with the next question from Martha. She's wondering if anyone is tracking any changes in the management of other chronic diseases such as MLS or strokes, because access to routine medical care might be currently diminished.
Yep. I can tell you anecdotally that we hear from our partners in the hospitals that, you know, they see much lower rates of the things they normally would be seeing coming in at a certain pace, like acute MI, a heart attack, or a stroke, or even surgical emergencies like gallbladders and appendectomies, which means probably almost certainly that people are staying home at a time with illnesses and symptoms that should be causing them to seek care because of their concerns about exposure, and because people have taken to heart, you know, the message that they should stay at home. So we have to work to balance that message. I suspect nationally and globally that there are studies ongoing about the overall health impacts of this kind of these kind of restrictions on movement. And I know advocacy groups are, you know, around issues like hunger and abuse and violence. I know that among, you know, we have big recovery programs within PCHC. We have very serious concerns about our disconnection from those people and our ability to monitor for relapse, you know, through things like urine drug screens, which is the real use of urine drug screens, to monitor the stability of that disease. And when we can't do that on a reliable and consistent basis, we risk missing a person with opioid use disorder or other use disorders becoming unstable and intervening by intensifying their treatment program. So we're working to move very quickly back to reestablishing that kind of care in those circumstances. It's a very, very important concern. And as we work to maintain the safety of everybody, we have to continue to be innovative and creative in how we reassure people that when they need care, it's safe to come in for care, and that we'll do everything we can to offer that care and assessment in other ways, if it's appropriate, through telehealth, through home visits, through separation of areas of our healthcare delivery sites, to try and reassure people to the extent that they can be reassured, through universal masking, which we're doing in our healthcare delivery sites, interventions like that.
Thank you. And we have one more question in the chat box, which will probably be our last. But if you didn't get to ask one, feel free to enter it into the chat box now, or send me an email with the question and we can follow up. But our last question is whether you can speak about the efforts to educate the public and any medical preparations that are being taken for an expected second wave, particularly in our rural counties that haven't yet had community spread.
I think community education now is really, really important. We have the community's attention. If the pandemic wanes during the next few months, that will be a really critical time to maintain public awareness of all of this and to prepare people for, what we're being properly warned could be a devastating winter if we see a reemergence of COVID. And I think most public health experts, and I can only rely on their expertise, feel that this will resurge in the autumn and winter. And if that coincides with, it will coincide with influenza, what that impact may be, and how willing will our society be to respond to social distancing restrictions again if we have to tighten them down again once we've loosened them. I think is a very serious concern. I think in healthcare, we have to insist that people who are working in healthcare get influenza vaccines. There's no reason to allow somebody to work in healthcare who won't get an influenza vaccine unless there's a medical reason they can't, and those medical exemptions are very rare for influenza vaccine. And that we put in place the kind of measures in healthcare delivery circumstances that allow us to mitigate the spread of diseases like influenza as well as COVID-19. And fortunately, because COVID-19 is so much more transmissible, if we have effective measures in place for COVID-19 in healthcare circumstances, we'll have effective measures in place for diseases like influenza for the autumn and winter. I know, we all hope for a vaccine by midwinter, but, it's only a hope right now. As everybody knows in vaccine development, things can be looking really good for a long period of time, and then boom, you start to see a complication from the vaccine that makes it unsafe. Or you see that ultimately it isn't effective. And so I think January is a very optimistic view for the availability of a vaccine for widespread use. I think we have to plan for a full winter of dealing with this without a vaccine. Hopefully we have unlimited testing capacity by then, which will be a big help. Hopefully we know more about the treatment of the disease. Hopefully we know more about what makes people particularly vulnerable and how to protect them, and put all of these measures in place structurally to protect people when they do have to be in public, while we educate the public about the realistic relative long-term need for ongoing social distancing, and meeting their emotional needs in that context.
Thank you so much. So we do have only a minute left, so we'll be ending now. I want to thank you, Noah, for being with us today, and for everyone else for joining us for the call and asking your great questions. This has been part of our Public Health Epidemiology and Infectious Disease webinar series. So we'll continue these through the month of June. And our next one is on May 21st, and that's on infectious disease surveillance. And that will be with Jen Gunderman of the Maine Area Health Education Centers, she's also an MPHA board member. So you can see our full lineup of webinars and register if you just follow the bit.ly link, and we'll include that in the follow-up email as well, along with a recording of the webinar and answers to any of the questions we didn't get to. So thank you all so much, especially to you, Noah, and enjoy the rest of your day, everybody.
Thank you, everybody.
Thank you.